Hi, welcome to my ECG video blog. I'm Ken Grauer, and this is my 8th ECG video blog. The topic today involves the basics of AV block, including how to recognize what is and is not AV block, and how to determine the type and likely clinical significance of AV block when it is present in a matter of seconds, because that's all it usually takes. In future videos, we'll cover more intricate and advanced examples of AV block and AV block mimics, but for now, this video is devoted to the basics. Once again, for your convenience, I've made a website that lists key links to my ECG blog, my video blogs, and my introductory and advanced books and EPUBs on ECG interpretation. Above all is my email address. Please write me with your comments, feedback, and questions. On to today's topic. Let's start with what AV block is not. AV block is not this: a rhythm in which we start out with 2 sinus-conducted beats, and then what happens? We have a brief pause, but this is not AV block, because there is no P wave where we expect the next P wave to occur, red arrow. One key criterion of AV block that is commonly overlooked is that the underlying atrial rate should be regular, or at least almost regular, with usually no more than slight variation in the P to P interval being seen if there happens to be some sinus arrhythmia. But this is not the case here, since no sinus P wave occurs where it should occur between beat 2 and 3. Instead, what happens at the beginning of the pause within the red circle? Compare what you see within the red circle with the very smooth ST segment of the preceding beat within the blue circle. See the notch within the ST segment of beat number 2, white arrow. This is a blocked PAC. This premature atrial contraction occurs so early within the ST segment that the ventricles are refractory, and this PAC is not conducted. We know that the notch highlighted by the white arrow is real and not just artifact because the ST segment of all other beats on this tracing is smooth, blue circles, except at the onset of the 2 short pauses on this tracing. So despite the group beating that is seen on this tracing, this is not AV block. Remember, the most common cause of a pause is a blocked PAC, which in real life occurs much more often than any form of AV block that you might see. Before getting into what AV block is, I'd like to show one more example of what AV block is not. In this right-sided MCL1 monitoring strip, the rhythm begins with 3 sinus-conducted beats, red arrows. What happens after these 3 sinus-conducted beats? An extended pause is seen that lasts for more than 4 seconds. That said, this is also not AV block because no sinus P waves occur where they should occur during this extended pause. We can easily recognize that this rhythm is not AV block because regular P waves are not seen. Assuming no reversible cause of this pause is present, such as overuse of rate-slowing medication, this patient probably has sick sinus syndrome and will likely need a pacemaker, but there is no AV block. What then is AV block? It is simply a problem with conduction of supraventricular impulses through the AV node. As we have emphasized, there should be a regular, or at least almost regular, underlying atrial rhythm. The problem is that some or all of these atrial impulses fail to conduct through the AV node despite having more than adequate opportunity to do so. Or, if these atrial impulses do get conducted, their passage through the AV node on their way to the ventricles is delayed. Awareness of what AV block is not, as we've tried to highlight on this initial slide with these 2 clinical examples, is key to recognizing AV block when it does occur. So, On to discussion of how to recognize and classify the AV blocks. Let's look at normal conduction. Normal conduction begins in the SA node. The impulse travels through the atria via specialized conduction pathways to arrive at the AV node. We can summarize the process and the overall net direction of atrial depolarization by the red arrow. It's important to appreciate that conduction slows down when passing through the AV node, so that a large portion of the PR interval is spent trying to get through the AV node. Once the impulse gets through the AV node, it enters the bundle of His and the ventricular conduction system, and provided there is no bundle branch block, it is rapidly conducted via Purkinje fibers throughout the ventricles. We summarize this process and the net direction of ventricular depolarization by the blue arrow. So, SA node, travel through the atria to arrive at the AV node, slow but progressive passage through the AV node, entry into the His and bundle branch system with rapid conduction throughout the ventricles. That's normal. What then happens when there is AV block? To answer this, let's think about the 3 degrees of AV block. The possibilities are that passage of the atrial impulse may be delayed in getting through the AV node, that some atrial impulses may get through but others don't, or that none of the atrial impulses get through to the ventricles. With the mildest form of AV block, which is 1st degree, all atrial impulses are conducted and arrive at the ventricles. They just take longer than usual to get there. So conduction is slow through the atria, and especially through the AV node, but once the impulse arrives at the AV node, it is quickly and normally conducted through the ventricles. In contrast, with 2nd degree AV block, some but not all atrial impulses are conducted to the ventricles, with there being 3 types of 2nd degree AV block based on severity, as we'll see momentarily. So, some impulses get through, but because of the block, others don't, which leaves the most severe form of AV block, which is 3rd degree. With 3rd degree, none of the atrial impulses are conducted to the ventricles, which is why we call 3rd degree complete AV block. So there is complete AV block, with the sinus node continuing to give off impulses, but none of them getting through to the ventricles. Let's look at one last concept before classifying the AV blocks, which is the concept of escape. Under normal circumstances, that is with normal sinus rhythm, the sinus or SA node serves as the principal pacemaker of the heart. As such, the SA node normally puts out between 60 to 100 regular impulses per minute, which defines the normal rate range for sinus rhythm in adults. But what would happen if, for whatever reason, the SA node fails? If nothing happens, the result will be asystole. So if no other pacemaker takes over the role of the SA node and the SA node stops firing, the result will be a flat line and the patient will die. This is why hopefully an escape pacemaker will arise from some other site in the heart. This could be from elsewhere within the atria, although most often it will be from the next in line intrinsic pacemaker, which is the AV node. The QRS complex in an AV nodal or junctional escape rhythm is narrow, and the QRS complex is not preceded by a P wave. Or if a P wave is present, it is negative in lead 2, white arrow. The usual AV nodal escape rate is between 40 to 60 per minute, or just below the lower limit for normal sinus rhythm. Pearl. Although the QRS complex of a junctional escape rhythm is narrow and generally looks very much like the QRS complex of normal sinus beats, at times there may be slight differences in QRS morphology that suggest its origin from outside the sinus node. These differences may be subtle, such as the tiny S wave seen here for the junctional escape beats within the red oval, compared to the normal sinus beats that do not have any small S wave within the blue ovals. Beyond the core, these small, subtle differences in QRS morphology, when they are present, may sometimes help to distinguish between sinus-conducted beats versus beats from some other escape focus that arises from within the conduction system. But let's get back to basics. What if the AV node also fails? That is, there is no sinus impulse and no AV nodal escape. In this case, the last hope is that a slow idioventricular escape pacemaker may arise to take over the pacemaking function and save the heart from asystole. If this happens, the escape QRS complex will be wide because it originates from the ventricles, and this wide QRS will not be preceded by any P wave. The intrinsic rate of a slow idioventricular pacemaker is usually between 20 to 40 beats per minute. This is clinically relevant. The importance of being aware of the different potential sites for an escape pacemaker is that complete AV block may occur at either the level of the AV node, in which case the QRS complex of the escape pacemaker will be narrow at a rate between 40 to 60 per minute, or complete AV block may occur at a lower level, that is below the AV node, in which case the escape pacemaker will have to arise from the ventricles, in which case the QRS complex of the escape pacemaker will be wide and much slower, most often at a rate of between 20 to 40 per minute. What then happens with AV block? We classify the AV blocks by degree, of which there are 3. We like to keep classification of the AV blocks simple, which we do by the keeping it simple or KISS method. It goes like this. First degree AV block is easy to recognize. It's just a sinus rhythm with a long PR interval. Most of the time, third degree or complete AV block will also be surprisingly easy to recognize, as we'll see in a minute. Therefore, keeping it simple, if you have AV block and the block is neither first degree nor third degree, then it's got to be a type of second degree AV block. KISS method. Let's start with the mildest form of AV block, which is first degree. This is simply a sinus rhythm with a long PR interval. Remember that with ECG grid paper, each small box takes 0.4 seconds to record, and each large box, which contains 5 small boxes, takes 0.4 times 5, or 0.20 second, which is 1/5 of a second, to record. Therefore, a long PR interval can be easily determined by seeing if it takes more than one large box, or more than 0.20 second, to record. I'll emphasize that this upper normal duration for the PR interval holds true for adults. The heart of a young child is significantly smaller, therefore upper normal duration limits for the PR and QRS intervals are correspondingly shorter, such that a PR interval of only 0.19 second might be long, depending on the age of the child. But for adults, we say the PR interval is long if it clearly measures more than one large box in duration. Key points. The clinical significance of isolated first-degree AV block is minimal. That is, even if the PR interval is markedly prolonged, if this is the only ECG abnormality you have in an otherwise healthy adult, it is usually not of clinical significance. Keep in mind that normal healthy athletes often have PR intervals of 0.21 second or more, which is due to the fact that the AV node may be influenced by an increase in vagal tone. Therefore, we generally undercall the finding of first-degree AV block unless the PR interval is clearly more than one large box in duration. We also prefer not to use the term borderline when describing the PR interval because what are you saying? If the PR interval is borderline, say 0.19 to 0.20 second in duration, then you almost have a finding that even if you did have would mean absolutely nothing. Therefore, we prefer to describe the PR interval as either being normal or long, and we undercall PR prolongation unless there is absolutely no doubt that it is present. Let's see what this all looks like on the ECG. This is a normal sinus rhythm. Each QRS complex is preceded by a P wave with a fixed and normal PR interval. What happens? Remember, we defined first-degree AV block in adults as sinus rhythm with a PR interval that is clearly more than one large box on ECG grid paper, which means that the PR interval is at the least 0.21, if not 0.22 second or more. What is the PR interval on this tracing? Isn't it clearly more than one large box in duration? We estimate the PR interval in this tracing to be about 0.30 second in duration, which raises the question as to how long the PR interval can be and still conduct to the ventricles. The answer is suggested on this next tracing, in which the PR interval is very long, at least 0.50 second, yet it still conducts to the ventricles. There are cases on record in which a PR interval of 1 second or even longer has still been shown to conduct to the ventricles. So, what's happening here? Our first priority is the same thing we do first when assessing any cardiac rhythm, which is make sure that the patient is hemodynamically stable, since management priorities will clearly be different in the unstable patient. Since our focus in this video is on rhythm diagnosis, let's assume all of the rhythms that I show come from patients who are hemodynamically stable. So, given that this patient is stable, I approach rhythm diagnosis of the AV blocks in the same way I approach diagnosis of any other arrhythmia, by the P's, Q's, and 3R approach. Let's start with P waves. There is regular atrial activity in this tracing, red arrows. Even though we can't quite see atrial activity as well as we would like in all parts of the tracing, the overall regularity of the P waves we do see, plus the suggestion of notching within the ST segments highlighted by the white arrows, suggests that the atrial rhythm is indeed regular throughout. How about the QRS? The QRS complex is wide, clearly more than half a large box in duration. And the ventricular rhythm is regular, green arrows. We count 9 large boxes in the R to R interval, which gives us a ventricular rate of just over 30 per minute. This leaves us with the 3 R's. We've already looked at regularity and the ventricular rate, which are 2 of the R's, so we now need to assess the third R, which is whether P waves are related to the QRS complex. And the answer is no, as we see a constantly changing relationship between P waves and the QRS complex that is closest to each P wave. The rhythm for this tracing is therefore third degree or complete AV block. What then are the criteria for complete AV block? First, there should be a regular, or at least almost regular, atrial rate. I say almost regular because there may be slight variation in the P to P interval due to underlying sinus arrhythmia. But all P waves should look the same, and there should not be great variation in the P to P interval, which distinguishes complete AV block from blocked PACs or sinus pauses. In addition, the ventricular escape rate should be regular, or at least almost regular. pearl. If the ventricular escape rate is not regular, suspect that the rhythm is not complete AV block. Instead, it may be that early beats are conducted. This is because when AV block is complete, then nothing gets through to the ventricles, in which case an escape pacemaker will hopefully take over the rhythm, and most of the time, the intrinsic rate of an escape pacemaker will be at least fairly regular. So when there is complete AV block, we will usually see both a regular atrial rate and a fairly regular ventricular rate, but no relation between P waves and the QRS because there is no conduction. This will be seen as a continually varying PR interval before each QRS complex. The pearl is that when the ventricular rate of a rhythm with some AV block is not regular, then there is likely to be at least some conduction, which means that the block is probably not third degree. When there is complete AV block, there is no conduction. As a result, P waves are said to march through the QRS. Said another way, there is complete AV dissociation, which means that P waves are completely unrelated to the QRS. That said, the key criterion for making the diagnosis of complete AV block is that no P waves conduct despite being given adequate opportunity to do so. This means that the ventricular rate needs to be slow enough, usually 50 per minute or less, and the period of monitoring long enough for P waves to occur in all phases of the R to R interval so that they have adequate opportunity to conduct, but still fail to do so. For example, these P waves would not be expected to conduct, white arrows, because they occur during the refractory period. But virtually all other P waves on this tracing should be expected to conduct, yet none of them do. So this tracing shows complete AV block at the ventricular level with a wide complex escape rhythm occurring at a typical ventricular escape rate of between 20 to 40 per minute. Does the QRS complex always have to be wide for there to be complete AV block? And the answer, of course, is no, with it depending on where in the heart the AV block occurs. If the block is low down, that is below the level of the AV node, then the escape focus will have to arise from the ventricles, which results in a wide QRS and slow ventricular rate between 20 to 40 per minute, similar to the example of complete AV block that we looked at a moment ago. On the other hand, if the level of AV block is higher in the conduction system, that is either at the level of the AV node or within the bundle of His, then the QRS complex of the escape focus will be narrow because the escape focus is arising from within the conduction system. Most often this escape will be from the AV node, as is schematically shown here, in which case the rate of the escape focus will be between 40 to 60 per minute. Occasionally, the escape focus may arise from a little bit lower down, but still from within the conduction system, that is, within the bundle of His, in which case the QRS will be narrow and the rate a little bit slower. That said, more important than whether the site of the escape is from the AV node or from the His is that the finding of a narrow QRS tells us that the escape focus is arising from somewhere within the conduction system. So what is happening here as we look at this long lead 2 rhythm strip? As always, we assess the rhythm by the P's, Q's, and 3R approach. So we see there are regular P waves. The QRS complex is narrow, and the ventricular rhythm is regular at a rate of approximately 60 per minute. But there is no relationship between P waves and their neighboring QRS complex. The easiest way to see this is to look in front of each QRS complex on the tracing and look at the preceding PR interval. The PR interval is constantly changing, and none of the P waves are conducting. Some P waves are not expected to conduct because they either occur during the refractory period or have a very short PR interval, white arrows. But other P waves on this tracing occur at times when they should conduct, red arrows, yet they still fail to do so. Thus, we have complete AV block at the AV nodal level with a narrow escape rhythm occurring at the expected AV nodal escape rate of between 40 to 60 per minute. So, how about this tracing? Is this another example of complete AV block at the AV nodal level? Looking closer at this rhythm strip, the QRS complex is narrow and P waves are regular throughout the tracing. At first glance, P waves appear to be unrelated to their neighboring QRS complex, as seems evident for the varying PR intervals. So there is AV dissociation, and there appears to be at least some degree of AV block. But is the degree of AV block complete? Hint: is the ventricular rhythm regular? It looks to be regular, at least for the first 4 beats, green arrows, but then what happens? Beat number 5 occurs early. This is where we would expect beat 5 to occur, but instead it comes early. When the ventricular rhythm is not regular, this is a big clue that the degree of AV block may not be complete. If we now look closer in front of the QRS complex for the last 3 beats, we can see that the PR interval before beats number 4, 5, and 6 is constant, which means that these beats are conducting. So the rhythm is not complete AV block. But the clue that complete AV block was not present was that beat number 5 occurred earlier than expected, which prompted us to look extra carefully at the PR interval preceding the last few beats on the tracing. Let's finish this section on third-degree AV block with a few final examples of some other stuff that should not be confused with complete AV block. For example, why is the tracing shown here not an example of AV block? Hint: what's missing? By the P's, Q's, 3R approach, the QRS complex is wide, the ventricular rhythm is slow and regular at a rate just over 30 per minute, but atrial activity is nowhere to be found. Remember, for there to be AV block, there should be an underlying regular, or at least almost regular, atrial rhythm, because by definition, it is the non-conduction of P waves that defines the condition of AV block. So when P waves are absent, there is no AV block. Instead, the tracing here shows a slow ventricular escape rhythm occurring at the expected ventricular escape rate of between 20 to 40 per minute. What if instead we change the appearance of this rhythm a little bit and tell you that the patient is on dialysis? The main difference we see relates to the presence of tall peaked T waves, which in a patient on dialysis strongly suggests there is hyperkalemia. Remember, with marked hyperkalemia, usually with serum potassium levels over 7 milliequivalents per liter, P waves become smaller, and ultimately P waves are lost, while the QRS complex becomes wider, in addition to the tall, peaked appearance of T waves. So, development of a slow, wide rhythm without P waves in a patient predisposed to developing hyperkalemia should suggest this diagnosis. But this is not third-degree AV block. 2 quick final examples. First, what happens here? The rhythm begins with 2 normal sinus beats, but after this, there is ventricular standstill. P waves continue, but there is no QRS. Ventricular standstill is worse than complete AV block because there is no escape rhythm, which means that the patient will die unless a pacemaker is promptly placed. And an even worse response is shown here, in which there is nothing after 2 normal sinus beats, which we call asystole, again with prompt need for pacing if the patient is to survive. But the point we make here is that asystole is not AV block, but rather complete cessation of electrical activity. This leaves us with the second-degree AV blocks, in which some but not all P waves are conducted to the ventricles. Remember, by the KISS method, if AV block is present, but the degree of block is not first degree and not third degree, then it's got to be one of the forms of second-degree AV block, of which there are three types. Mobitz type 1, which is really a synonym for AV Wenckebach, Mobitz type 2 second-degree AV block, and the third type of second-degree AV block, which is the one that is often forgotten, namely second degree with 2-to-1 AV conduction, in which we cannot tell if this form of second-degree AV block represents Mobitz I or Mobitz II. And finally, there are a few other terms, including high-grade AV block and AV dissociation. We'll conclude this video by clarifying these terms. Let's look at Mobitz type 1 second-degree AV block, also known as AV Wenckebach. As always, we'll assess the rhythm with the P's, Q's, 3R approach. The QRS complex is narrow, that is clearly not more than half a large box in duration. The atrial rhythm is regular, with a constant P to P interval, but the ventricular rhythm is not regular. Instead, we see groups of beats. Beats 1, 2, 3, then beats 4, 5, and then beat number 6. Within each group, the PR interval progressively lengthens. Red arrow, blue arrow, green arrow, until a beat is dropped, yellow arrow, and then the cycle resumes, black arrow, with a short PR interval at the beginning of the next group of beats. Mobitz I is by far the most common form of second-degree AV block. In our experience, Mobitz I makes up well over 90% of all second-degree AV blocks, so it's important to recognize. Fortunately, recognition becomes much easier if we look for the footprints of Wenckebach, of which there are several. As suggested by these footprints in the sand, the footprints we see here are paired, so there is a pattern in the form of 2 footprints per group, which corresponds to the hallmark feature of AV Wenckebach, which is group beating. Let's look at a clinical example. This is AV Wenckebach. Note groups of beats. It is sometimes better to step back a little bit from the tracing, which better allows you to appreciate group beating when it is present. Be aware that the groups are not always perfect, as they are here with alternating short, long intervals. But with practice, recognition of a pattern of group beating is easy, which is important because it is this feature that prompts us to begin thinking about the possibility of Wenckebach the moment we see this tracing. Note, group beating will not always indicate AV Wenckebach, as other entities, such as conducted or blocked PACs or SA block, may also produce groups of beats. But group beating should prompt you to consider Mobitz I as you begin your systematic approach. So, for this tracing, we see that the QRS complex is narrow, P waves all look the same and the atrial rhythm is regular, and within each group of 2 beats, dotted green rectangle, the PR interval is increasing, red to blue arrow, until a beat is dropped, yellow arrow, and then the pattern repeats itself, as we see here with the last 2 groups of beats. So the reason for group beating in this tracing is Mobitz type 1 second-degree AV block, seen here with 3-to-2 AV conduction. That is, of the 3 P waves present in each group, 2 of them conduct, red and blue arrows, therefore 3-to-2 AV conduction. In addition to a regular, or at least almost regular, atrial rate, group beating, and progressively increasing PR interval until a beat is dropped, there are other footprints of Wenckebach. Some of these, like PR-RP reciprocity and progressively decreasing R2R intervals, extend beyond the core of this basic video on AV block, although we mention them for completeness. But one additional footprint that we often do use is that with Wenckebach, the pause that contains the drop beat will generally be less than twice the shortest R2R interval. Use of this footprint helps us to recognize potential mimics of Mobitz I, such as sinus pauses or blocked or unblocked PACs. Let's illustrate this concept by using this example of Mobitz I that we discussed earlier. Note the progressively increasing PR interval, red arrow to blue arrow to green arrow, until a beat is dropped, yellow arrow. So this rhythm clearly is AV Wenckebach. So we look to see if the pause containing the drop beat is less than twice the shortest R2R interval. This is the shortest R2R interval. Note that the pause containing the drop beat is clearly less than twice the shortest R2R interval, so that this example of Mobitz I exhibits typical Wenckebach periodicity. Pearl that is beyond the core. The reason we specified AV Wenckebach as the equivalent of Mobitz I rather than just Wenckebach is that there are many other rhythms that may on occasion manifest Wenckebach conduction. These include atrial fibrillation or flutter when there is group beating, SA block, junctional escape rhythms, and even VTAC with retrograde Wenckebach conduction to the atria, to name just a few. Awareness of group beating and these other footprints of Wenckebach periodicity can help us to recognize when Wenckebach conduction may be present, even when we do not completely understand the mechanism of these complex rhythms. But all group beating is not necessarily Wenckebach. So as helpful as recognizing group beating is for suggesting the possibility of Wenckebach, there are other causes. Consider this tracing, in which we see a repetitive pattern with several groups of beats, blue brackets. Despite group beating, why is it that this rhythm is not AV Wenckebach? Hint: are the other Wenckebach footprints present? Let's look at these one by one. The atrial rhythm is not regular, red arrows. Not all P waves look alike, blue arrows. So an atrial focus other than the SA node is operative. The PR interval within groups of beats is not increasing, red brackets. And when we look at the pauses that occur in this tracing, there are no non-conducted P waves, as there should be with Mobitz I. Finally, note that each pause is clearly more than twice the shortest R2R interval, with the reason being that every third beat is a PAC, blue arrows, that then resets the SA node to produce a longer pause than would be expected if this was Mobitz I. Bottom line, while the clue of group beating may be helpful most of the time in suggesting that AV Wenckebach may be present, there are other causes of group beating. That said, by keeping in mind the footprints of Wenckebach, it will usually be fairly easy to tell if Mobitz I second-degree AV block is or is not present. Let's now look at Mobitz II second-degree AV block. As opposed to Mobitz I, in which the PR interval progressively lengthens until a beat is dropped, with Mobitz II, the PR interval remains constant. And then, often without warning, one or more P waves in a row may be non-conducted. We see this in the example of Mobitz II shown below on this slide. Note that regular sinus P waves are present throughout, red arrows. The QRS complex is wide, as it usually is with Mobitz II. This is in contrast to Mobitz I, for which the QRS complex is most often narrow unless there is pre-existing bundle branch block. This is because the block with Mobitz I generally occurs at a higher level in the conduction system, usually around the AV node, whereas with Mobitz II, the block occurs lower down, so the QRS complex will almost always be wide. Since the right coronary artery most often supplies the AV node, Mobitz I is typically associated with acute inferior infarction, whereas Mobitz II is usually associated with anterior infarction. Mobitz II is much less common than Mobitz I. In our experience, 90, if not 95% of second-degree AV blocks are Mobitz I. The problem is the disturbing tendency for Mobitz II to suddenly develop profound block, even ventricular standstill. Note consecutively non-conducted P waves in this example, yellow arrows, as well as single non-conducted P waves that occur later in the tracing. As a result, even though Mobitz II is relatively uncommon, it is essential to recognize Mobitz II when it does occur, because short-term and long-term pacing will often be needed. In contrast, Mobitz I is most often a transient conduction disturbance that generally resolves in the hours to days following an acute event, such that permanent pacing will much less often be needed. The key to diagnosing Mobitz II, which is often overlooked, is that in order to make this diagnosis, you have to see somewhere on the tracing at least 2 or more consecutively conducted beats before 1 or more beats are dropped. Otherwise, there is no way to know if the PR interval would increase if given a chance to do so. In this example, the diagnosis of Mobitz II is secure because there are 3 consecutively conducted sinus beats at the beginning of this tracing in which the PR interval remains constant, red brackets, before non-conducted P waves, highlighted by the yellow arrows, are seen. So, to summarize key differences between Mobitz I and Mobitz II forms of second-degree AV block, remember, as a memory aid, that 1 comes before 2. So, Mobitz I is much more common than Mobitz II. As to the level of the block, 1 comes before 2. So, Mobitz I generally occurs at a higher level within the conduction system, usually from within the AV node. As a result, the QRS complex tends to be narrow with Mobitz I. In contrast, Mobitz II occurs from lower down in the conduction system, which is why the QRS is usually wide. Mobitz I is often associated with inferior infarction. The narrow QRS and AV nodal location explains why Mobitz I may respond to atropine, especially if given to patients with acute inferior MI during the early hours of infarction when vagal tone is often increased and responsible for the AV block. Mobitz I rarely needs pacing. In contrast, Mobitz II is associated with anterior MI, it doesn't respond to atropine, and both short-term and long-term pacing is much more likely to be needed. So, what's happening here? What kind of second-degree AV block is seen on this tracing? Using the P's, Q's, 3R approach, we see that the QRS complex is narrow, and regular P waves are present, red arrows. But every other P wave is not being conducted to the ventricles, yellow arrows. However, if we look in front of each QRS complex that is seen on this tracing, each QRS is preceded by a P wave with a fixed PR interval, red brackets. Therefore, every other P wave is being conducted to the ventricles. So we have a second-degree AV block in which some P waves are conducted, but others are not. There is 2-to-1 AV conduction because for every 2 P waves, only 1 is conducted to the ventricles. Is this Mobitz I or Mobitz II? Key point. When there is 2-to-1 second-degree AV block, we cannot tell for sure if the rhythm is Mobitz I or Mobitz II because we never see two conducted beats in a row, which means that we can't tell if the PR interval would increase if given a chance to do so. That said, there are some things we can look at to help us determine which form of second-degree AV block is more likely to be present. First, Mobitz I is far more common than Mobitz II. In addition, the QRS complex seen here is narrow, so statistically, the odds that the 2-to-1 block seen here represents Mobitz I are already well over 90%. We could increase these odds even further if we knew whether this patient was having an acute inferior MI. Finally, we could virtually prove Mobitz I if we saw evidence on this patient's telemetry of other rhythm strips that clearly showed a progressively increasing PR interval until a beat is dropped. For example, what if a little bit later the same patient showed this rhythm? This new rhythm begins in the same way as the one we just saw, with regular sinus P waves, and with every other P wave not being conducted, yellow arrows. Looking in front of each QRS, we once again see that the PR interval is fixed, red brackets. So this new rhythm once again begins with 2-to-1 second-degree AV block. But then, what happens? Regular sinus P waves continue, and another P wave is not conducted, yellow arrow. But the difference is that there are now two conducted beats in a row, which now allows us to see that when given a chance, the PR interval is increasing until a beat is dropped. So we do now have clear evidence of Mobitz I at the end of this tracing. Although not impossible, it is extremely unlikely for the rhythm to go back and forth from Mobitz I to Mobitz II, which means that the 2-to-1 AV block we saw earlier almost certainly was Mobitz I. Clinically, this distinction is important to make because a pacemaker is unlikely to be needed with Mobitz I. This leaves us with two final concepts: AV dissociation, which we address in a moment, and the nebulous term high-grade AV block. High-grade AV block is a form of second-degree AV block because some P waves are conducted, whereas with third-degree or complete AV block, no P waves at all are conducted to the ventricles. Consider this clinical example. There are 3 QRS complexes on this tracing. It is easy to see that the ventricular rhythm is not regular. The QRS complex is narrow, and regular sinus P waves are seen throughout. The 3 ventricular beats that we see are conducted. We know this because the PR interval preceding each of these 3 QRS complexes is the same, red brackets. But other than these 3 beats, none of the other P waves on this tracing are being conducted, yellow arrows. Thus, we have second-degree AV block, because some, but not all P waves are conducted. The narrow QRS favors Mobitz I, but Mobitz I rarely results in consecutive non-conducted P waves, as we see here. That said, because we never see 2 conducted beats in a row, we cannot determine with any certainty whether this tracing represents Mobitz I or Mobitz II. That said, regardless of whether this example of second-degree AV block is Mobitz I or Mobitz II, consecutive non-conduction of P waves with the resultant slow ventricular rate produced here is of concern and may require pacing unless the ventricular rate can be increased. In such situations, we find use of the term high-grade AV block a convenient way to convey concern for selected cases of AV block that otherwise defy classification. This leaves us with the final concept of this video on AV block basics, which entails understanding what is meant by the term AV dissociation. If we had to state one key message to leave you with, it would be that AV dissociation is not the same thing as complete AV block. Third degree or complete AV block means that there is no conduction. None of the atrial impulses penetrate the AV node, despite having adequate opportunity to do so. In contrast, AV dissociation simply means that some P waves are not conducting. There is a regular atrial rate, but for whatever reason, there are at least some P waves that are not conducted. The reason could be AV block, either second or third degree, or it could be either by default, in which the rate of the sinus node slows, or by usurpation, in which the rate of the escape pacemaker accelerates. To explain, a picture is worth 1,000 words. What's happening here? The QRS complex is narrow. Regular sinus P waves are seen throughout the tracing, albeit at the relatively slow rate of 50 per minute. If we focus on the first 3 beats in the tracing, the rhythm begins with sinus bradycardia, as the QRS complex for each of the first 3 beats is preceded by an upright P wave with a fixed and normal PR interval, red brackets. But then, what happens? Look at the last 3 beats on the tracing. Is the P wave still conducting for beats number 4, 5, and 6? We can definitely say that the PR interval preceding beats 5 and 6 is too short to conduct, yellow arrows. It is probably also too short to conduct beat number 4, green arrow. At the very least, there is transient AV dissociation. Question: is this AV block? Hint: do any of these P waves that precede beats number 4, 5, and 6 have a chance to conduct? The answer is no, because the PR interval is simply too short to allow these P waves an opportunity to conduct to the ventricles. Instead, an AV nodal escape rhythm takes over. This is AV dissociation by default. That is, default of the sinus pacemaker that has slowed down here to a rate just below 50 per minute, which allows the normally functioning AV node to put out an escape pacemaker at the normal AV nodal rate of between 40 to 60 per minute. There is no evidence of any AV block, despite the fact that the last 3 P waves on this tracing are not conducting. So, AV dissociation is not the same thing as AV block, and at times, AV dissociation may even be a good thing, because without the AV nodal escape rhythm seen here, this subject's heart rate would have slowed down even more. In contrast to AV dissociation by default is AV dissociation by usurpation. Consider this rhythm strip. The QRS complex is narrow throughout, so the rhythm is supraventricular. The tracing begins with sinus rhythm for the first 2 beats, and then what happens? Although we might be uncertain if beat number 3 is conducting, there should be no doubt that the PR interval preceding beats number 4 and 5 is clearly too short to conduct. Therefore, there is AV dissociation, because there are regularly occurring sinus P waves that are not conducting. But AV dissociation should never be a diagnosis by itself. Instead, we need to find out why there is AV dissociation, with the 3 possibilities being AV block, or default, due to sinus rate slowing, as we saw in the last slide, or usurpation, in which the AV nodal rate accelerates. This latter possibility is precisely what we have here, in which a junctional tachycardia at a rate of 100 per minute takes over during the last half of the tracing, green arrows. So, we once again ask the question, is there evidence of AV block on this tracing? With this begging the additional question as to whether the non-conducting P waves ever had a chance to conduct. The answer is that they did not. Yellow arrows, because the PR interval preceding beats number 4 and 5 is too short to conduct, with the reason for non-conduction being that an accelerated junctional rhythm usurped, that is, took over, the underlying rhythm. Final point. The diagnosis for the rhythm on this slide is not AV dissociation, but rather junctional tachycardia that produces AV dissociation by usurpation. There may or may not be any degree of AV block. We just can't tell from the short lead 2 rhythm strip seen here. This distinction is important clinically because the AV dissociation may spontaneously resolve if we can find out and treat the reason for the AV nodal tachycardia. We conclude this video on AV block basics with review of the difference between AV dissociation versus complete AV block. Consider this tracing that we looked at earlier. Is there AV dissociation? Is there AV block? Are any P waves being conducted to the ventricles? If not, do at least some of these P waves have a chance to conduct, yet still fail to do so? We assess this rhythm by the usual P's, Q's, 3R approach. The QRS complex is wide, and the ventricular rhythm is regular at a rate just over 30 per minute, blue arrows. We see regular sinus P waves throughout, red arrows, but the PR interval continually changes, red brackets. So none of these P waves are conducting, which by definition means that there is complete AV dissociation. But for there to be AV block, P waves must have an opportunity to conduct, yet still fail to do so. We would not expect some of the P waves on this tracing to conduct, because they either occurred during the refractory period, yellow arrows, or precede the QRS with a fairly short PR interval that might not give the atria adequate time to transmit the sinus impulse to the AV node, green arrow. But most of the P waves on this tracing should conduct, red arrows, because they occur at a point in the cardiac cycle that clearly should allow adequate time for conduction. You may recognize this tracing as the example of complete AV block at the ventricular level that we showed earlier. All criteria for complete AV block are met, including regular atrial rate, regular ventricular rate that is slow enough, clearly less than 50 per minute, to allow adequate time for many of the P waves to have a chance to conduct, yet still not resulting in any conduction, as evidenced by the presence of regular P waves marching through the QRS with continually varying PR intervals in front of each QRS on the tracing. It's time to stop. We've covered lots of material in this video on AV block basics that we will reinforce in future videos and posts on our ECG blog. This is Ken Grauer saying goodbye for now.